Thank you so much and welcome everyone.
Thank you so much for having me here today. I'm excited to be presenting to another Midwestern region because I think we have a lot of ways that we can synergize and share together. It's a pretty small group. I'll try to keep my eye on the chat. But if Zora or Nicole could feel free to jump in and stop me if there's questions, because it's hard to know with Zoom, you don't get that like feedback as you get in a live room. So just feel free to stop me in between. The first set of slides is really sort of about treating opioid use disorder. I know that this is a group of folks that are heavily engaged in that, so I'm going to zoom through some of those slides. But you can send them out for anybody who's interested, and if you don't have a copy, Heather can email it to you as well, just so that people aren't like, oh my gosh, she's going so fast. But we really wanted to focus on that healthcare system change, the change management, and the advocacy piece of things. So if you just in case that so hopefully this will be more focused on that than on the how do you treat people with a substance use disorder, because I know this group is really involved in that already. Just really excited to see Rachel Jones here because I love my extension team, and I just wanted to give a shout out to extension. We've used them personally for so much agricultural help because I have a black thumb. So that's probably the biggest way that I've integrated as a community member and utilized their services. But they do a lot of outreach and engagement in the substance use disorder space in our community. So I just thank you for the work that I know you do, even if I don't know the specifics. So I don't have any relevant financial disclosures. So we're going to just touch on opioids quickly here. Like I mentioned, I'm going to kind of breeze through these slides, but they can certainly act as a resource for anyone who feels they might be helpful. Opioid use disorder is increasing nationwide. I just a real quick caveat statement, where the literature specifies women, I have kept gendered information. I will try to use the words pregnant person and non-specific gendered language where I can, but just a disclosure, because I kind of flip between the two. Usually when I reference women, it's because that's how either the journal article or the information was cited. So about 1 in 5 people who are prescribed opioids during pregnancy report misuse. So because of this increased use of opioids during pregnancy broadly, we have a concurrent rise in neonatal opioid withdrawal syndrome or neonatal abstinence syndrome more broadly. So we can see it increase 82% from 2010 to 2018. This is Michigan specific data, really showing that maternal opioid use parallels the number of newborns born with opioid withdrawal of some sort. This is not different in other areas. However, I often find when I'm talking to administrators, being able to say specific data either to Michigan, or if it's been drilled down, if it's possible to drill it down to the county or regional level, that can be really helpful in terms of speaking to legislators, speaking to individuals. These are some data points pulled from NIDA's website, which again is often impactful for people to give them a scope in a quick pictorial way. There are a lot of potential complications with opioid use during pregnancy. I think the biggest one that I like to focus on in my advocacy piece of it is the lack of prenatal care. If we don't create safe spaces for pregnant people who are using opioids, whether prescribed licitly or illicitly, we are not doing a service to our community, and we are which results in worse care. And the number one reason that people don't come to prenatal care when they have an opioid use disorder is usually because we've been jerks to them as a healthcare system in the past. I'm sure I'm preaching to the choir on that one. But that is the one that we are trying to address by increasing these treatment opportunities for pregnant people with a substance use disorder, whether it's opioids or otherwise. But these are some that below you, I'm sure you've already read the rest of the other pregnancy complications and likely a review for this crew. So maternal opioid use has been shown to be neurotoxic to the embryo. It is notable that that neonatal opioid withdrawal syndrome is a time-limited thing. So that doesn't impact the child as they go through their development. What we see in terms of the studies that are kind of referenced up above, the consequences of the exogenous opioid within the developing brain, most of those are related to those ups and downs that we get when somebody is using fentanyl or another short-acting opioid. We actually, when you drill it down to those longer acting opioids, like those that we use in treatment of a substance use disorder, methadone and buprenorphine, we don't see those long-term consequences. The data is a little, admittedly, it's not the, cleanest data, but, the ultimately the best thing for that pregnant person and their developing embryo is to continue on the medications. Neonatal opioid withdrawal syndrome is specific to opioid use, and it does occur in a significant portion of children born to opioid dependent mothers. I do want to point out that a lot of these studies were done under the Finnegan scoring system, and that as people have moved to Eat, Sleep, Console, which is a more functional status evaluation method for that neonatal opioid withdrawal syndrome, we find that the number of babies that are diagnosed with withdrawal and the number that need medication to treat that withdrawal reduces significantly. In my clinic, only about 5% of our babies actually need medication to treat neonatal opioid withdrawal syndrome. It is not related to maternal dose of medication, which is an important counseling piece and an important piece to make sure that other members of the healthcare team are aware of and understand, particularly in the hospital. And that postnatal period, we've definitely had to educate people around that fact, because they were looking at somebody who was on 20 milligrams of buprenorphine differently than they were looking at somebody who was on, say, 8 milligrams of buprenorphine. And that's really quite inappropriate. These are some of the symptoms that come, the clinical manifestations of neonatal abstinence syndrome. The one that people have seen in the, via Dr. Google and Dr. YouTube is that high-pitched crying, and it looks like babies are really suffering, and providing a lot of reassurance for people that that's not actually what we do in the hospital. And that's why the importance of having financial support and integrating Eat, Sleep, Console into more treatment programs is really, really helpful. The onset of NAS is usually within 72 hours after delivery. However, with Eat, Sleep, Console, we do keep our babies up to 5 days in the hospital for monitoring to ensure we're not missing them. Certainly, babies who are born with neonatal opioid withdrawal stay in the hospital for quite a bit longer and cost the healthcare system quite a bit more. We talked a lot, I've already covered a lot about the treatment. I do want to point out that we really, for non-pharmacological management, I call this the warm cuddle stage. So we really want to support people in their ability to console their own child. We all know that babies calm down best to the person that carried them throughout that pregnancy. Not to diminish the non-pregnant person's, pregnant parents' role. I tell a lot of my usually dads in the office that, your baby does know you. There's this study where they looked at babies at about 2 weeks old, and they will turn, when they have neck control, they will turn their head towards dad's voice, preferably over another male's voice. And then people, we do want to encourage breastfeeding for people on any form of MOUD, as long as there aren't other contraindications, because that does also reduce the risk of opioid withdrawal. However, we do have to balance maternal mental health and breastfeeding support in that person's life, along with the benefits, to identify if that person might actually be a better candidate for formula feeding. I do want to point out that heavy smoking is associated with more severe neonatal withdrawal than opioid withdrawal is. So one thing that I think a lot of people, when patients come in and they're like, well, I want to reduce my MOUD treatment medications, I'm like, actually, let's talk about that smoking, because that smoking is more likely, or that vaping, that nicotine or tobacco use are more likely to be causing withdrawal in your baby than the medications that we're prescribing. And then there are, of course, pharmacological management methods as well. Again, with neonatal opioid withdrawal, there are no known long-term negative outcomes. And there are no long-term negative outcomes of that prenatal opioid exposure as well, when used in an MOUD setting. Again, treating opioid use disorder in pregnancy is crucial because of the benefits to the parent, the baby, the family, and the community they live in. The more we support these families, the more we provide them with teaching, training, education, the better off we are as a community more broadly. So treating opioid use disorder in pregnancy in our region, methadone is just not available in many areas of Michigan. I do work in Grand Rapids, so within the city limits, methadone is available. However, we have patients that drive to us from an hour and a half and 2 hours away where methadone just really isn't available. Buprenorphine can now be prescribed out of an office without a need for any type of waiver or additional training, as I'm sure the folks on this call are mostly aware of. So that hopefully will help us increase the amount of support that the amount of different offices that are providing this support in prenatal care. And there are many people that are trying to get treatment that cannot get the treatment. So the best practices for treating people during pregnancy are to really focus on those social supports. I had a medical student who's been, he's doing an MD PhD program. So he's been hanging out with me for about the last 7 years, as he's gone through 6 years, sorry, as he's gone through the first couple of years of medical school. I was a small group leader. And then now during his PhD program, he does his clinical time with me. And just yesterday, he said to me, I've been hanging out with you for a while, Dr. Poland. And I was like, yeah. And he said, I just have to say, I think that if we could solve the housing problems that your patients have, that would probably solve most of their needs. And I was like, yes, you are correct. That is correct. Good statement. Positive. That, those it was an opportunity, teachable moment, right? To talk about social supports and the privilege that we have sitting on the side of the equation that we're on. I do want to point out that while counseling can be an integral part of treatment, like I personally am of the total opinion, not evidence-backed at all, that every pregnant person should have 3 visits with a therapist, just because your life is going to radically change when that baby is born, whether it's your first baby or your 10th baby. And let's not even touch the hormones. So everybody could benefit from just having that sounding board. So I encourage all of my patients to do counseling, but the evidence is really against mandated counseling, which sort of makes sense, because if I tell you have to go to counseling and you're like, Dr. Poland, I don't want to go to counseling, that counseling is not going to be very beneficial. But I will tell you that I revisit that conversation. So if somebody comes in and things are looking different and they're hard in their life in some new way, I will revisit the counseling conversation. I am also a very spoiled physician, so I have a therapist that works with me in my office, so I can always pull Erin in. She's very, very scary and intimidating. We also, just as a side note, in Michigan, and I'm not sure if this is the same in Minnesota, but most of our child protective services folks are social workers. So we actually requested that her name badge be changed to not say social worker on it. It just says therapist instead, which is not inaccurate, but the term social worker had distinct meaning for our patients that was that was concerning to them. So just by changing her name tag, we found that it helped us better support our patients. So this is really just saying that all pregnant people should be given the opportunity to start opioid agonist therapy, and that's recommended by like all the major professional associations in the United States, as well as the World Health Association. So we don't detox people because 80 to 90% of people who we detox end up returning to opioid use during their pregnancy, which could be which has potential dangers for them. And then we also tend to not use naltrexone as a first-line treatment, because at the end of pregnancy we have this thing called labor, and we often want to use opioids to support pain and analgesia management during that labor and delivery process. However, there are some cases where that may be appropriate. Certainly something that we might want to reach out to a local addiction specialist to help us with, because I feel like that's out of scope for generalist OB. So there are a lot of maternal as well as fetal benefits of being on opioid agonist therapy that are pretty broad-based, and certainly benefits both the maternal as well as both the maternal health as well as the fetal health. And so we want to try to do our best to engage people into that treatment. It is notable that for the medications, doses generally increase during pregnancy. So we just like to, I like to raise that awareness, if only because we want to make sure that we're addressing those needs. This is because of the increased volume of distribution and the faster metabolism of these medications that can occur during this time. It's also the question that I tend to ask my patients is, how are you feeling just prior to your next dose? If somebody is merely saying they're having an increase in cravings, I'm talking to them about what else may be going on in their life that may be resulting in those increased cravings. But what I'm really looking for is right before you take your next dose, are you entering a significant trough level where you're starting to go into early or mild withdrawal? That's really what I'm looking for. The one thing I like to always point out to people is that we don't become tolerant to the pupillary effects of opioids. So if somebody's pupils are broadened when they're in the office and they're saying, "Hey doc, I need more medication," that's a good thing to take a look at, because if their pupils are indeed broadened, then they really aren't getting enough medication and they are likely in an amount of withdrawal. So looking for pupils to be a little bit smaller than you would anticipate, or at the appropriate size. Again, we want to maintain people on their medication and not taper them, and also include non-pharmacological treatments and support as well. Methadone and buprenorphine are both equally acceptable. Buprenorphine is associated with some improved baby outcomes. It also has increased availability, particularly for us in the Midwest and some of these more rural areas, where accessibility can be increased. There are some studies that show an improvement in retention for methadone clinics, although some of them have, although more recently some of that has been disputed a little bit. For people who would benefit from that higher level of care and service that you get with methadone, of course, that should be utilized where available. We are also starting to see that with some of these new fentanyl analogs that have higher potency, that it is becoming more difficult to utilize buprenorphine, that some people are indeed reaching a ceiling. We are also seeing an increase beyond that traditional 16 milligram maximum that we sort of thought previously was where buprenorphine hit the ceiling effect, but we're also having people that we go up to 24 or more milligrams, and they are simply not responding the way we want them to, and the medication just isn't working. And if the medication isn't working, we should do our best to transition them to methadone as well. The naloxone that is co-formulated with the buprenorphine is to reduce misuse potential. It's not really physiologically active. The buprenorphine monoproduct is still what is recommended according to all the national statements. However, most of those have not been updated since 2010, so they are moderately to significantly outdated. There are some limited studies showing decreased APGAR scores without naloxone that has been kind of called into question. And so we tend to prescribe the buprenorphine with naloxone for opioid dependence during pregnancy. But because of that misuse deterrent and the increased availability at things like pharmacies, I don't know about you all, but here in Michigan, we do have some pharmacies that are just not willing to carry the mono product as well, which so the availability can be better. In labor and delivery, it's important to make sure that our colleagues in the hospital are aware that people may have a higher opioid tolerance and a lower pain tolerance and need generally higher doses of medication to to adequately control their pain. And a reminder that those medications that are used in the treatment of opioid use disorder do not provide any form of analgesia for that patient. And then patients on naltrexone, if they come to the hospital and they're actively on naltrexone, that should be a consult to anesthesia. There's no generally agreed upon analgesia course for labor and delivery in this population, but if people are interested or would like a resource, I'm happy to share what we do at our hospital. But essentially, you continue the opioid agonist, maximize, acceptable to the patient, acceptable to your systems, non-opioid pain control, utilizing epidurals and regional blocks without opioids, if as possible, and then utilizing opioids in those epidurals as needed, and avoid other partial agonists like nalbuphine and butorphanol, which should be like a warning that comes up for somebody who's on full agonist or partial agonist opioid treatment, because those will precipitate withdrawal, including in somebody on buprenorphine. So it's really important for us all to be aware that the majority of maternal overdose deaths happen postpartum. In actually, those, if you combine these in the 4 to 12 months postpartum. So we really, we can keep our patients for up to 1 year before we transition them in that postpartum period. So it's good to remember that, while traditionally we would discharge people kind of partway through this months 0 to 3 for most prenatal care, we may want to consider extending that relationship out further in order to to keep those relationships, with the hopes that we might continue to be a safe place for these families. This is just saying the same thing. This is the Michigan specific data. Again, as I mentioned previously, you may want to look into what data you can get out of Minnesota directly, particularly for those advocacy conversations, and to establish that change management, both within your healthcare system, but also on a broader advocacy level with your legislature. Medication should absolutely be continued through the postpartum period. I don't know about anyone else, but I happen to have 2 children. And I will tell you, I don't think that I was all the way there in terms of my brain function for at least 18 months after my children were born. And we do most of our kind of brain cleanup when our bodies are at rest and when we are sleeping. And so if we try to taper people during that postpartum period, it can be very difficult on them. I mean, I will recommend to patients that we don't taper. However, if a patient is driven to taper, of course, I will support them through that. So just in general, for this kind of more didactic section of the talk, these are, we want to screen people during pregnancy and refer people or provide people with appropriate adequate treatment. And then we want to continue them on opioid agonist therapy, as detox is not recommended, and then continue that treatment for as long as we can in the postpartum period, including up to 1 year. So let's talk a little bit about how we created our clinic. I'm not going to talk a lot about the specifics of the day-to-day management, but hopefully the ask for me was to talk about advocacy and in moving those things forward. So here is kind of a case report on what we did in our system. We identified, I kept getting phone calls from the OB residency program that like, hey, Sally hasn't come for her last 3 prenatal appointments. And I was like, what do you mean? I just saw Sally 2 hours ago. She's been a rock star. She comes every week. And what we found was that when we did a chart deep dive, because these patients were getting a lot of judgment and stigma when they went into the hospital for a lack of prenatal care. And I was like, but they're coming for their STD treatment. Was that we were asking a lot of our patients, we were asking them to come to regularly, at least 2, sometimes 3 or 4 visits a week in different locations across our campus. And our campus is pretty big. It might only be 1.5 miles between the general addiction clinic and the OB residency clinic, but there are a crap ton of one-way streets in there, and it is hard to navigate. And then like pregnant people also often have these other things called toddlers. I don't know if you've heard of them before, but they have other kids, right? And so finding a sitter, taking time off of work, like these are all things that are hard to do, especially when we're asking people to do it multiple times a week. It makes it hard, if not impossible. So then the patients were logically prioritizing certain appointments, and truly, if somebody asked me which one I would recommend, it would please prioritize those MOUD visits, right? To make sure that you have your medication, because I'm writing the medications to the next visit, and not being on those medications is really physically not comfortable if somebody gets to the point of being in withdrawal. So, right. So like all of these things were working against the patient. We were being very healthcare centric and not patient centric. And so it pushed our patients away. But by doing kind of just a chart analysis of a dozen or so charts, it wasn't even that big of a project. We were able to show like where the structural issues were. And that really helped speak to people. We worked with our EPIC team and enlisted medical students. I guess it was more than that, to review 20 patients. I thought it was a dozen, but it was more than that. It was about 20 patients. And we did tally counts of just the number of visits attended, number of visits no showed or canceled, and if canceled, what the reason was, and then presented that to leadership as our sort of, rationale for why we needed to do something different. And what came of that was the Great Moms program in 2017, when addiction medicine, myself and our maternal fetal medicine healthcare team came together, and we started this program co-located in the MFM office. I'm just an internist. I'm not an OB, but I have the pleasure of working alongside a nurse midwife who provides the prenatal care and is just a fantastic human, and I love her to pieces. She's going to retire at the end of the year, she's threatening, and I may end up like crying in a corner for months when she does that, because I'm going to be very, very sad. But I suppose it's okay because she's turning 69 this year, so it seems reasonable that she might want to stop working, but I'm really going to be sad when Nancy stops working. So I have that. So we have a team of 3. I mentioned our therapist, Erin, who is a LMSW with a CAADC license as well. And Erin and I are also both EMDR trained. And then Nancy, I'm the addiction medicine physician, and then Nancy is a certified nurse midwife who provides the prenatal care. So we really kind of work together. We are co-located with MFM. So if somebody has some other reason that they need to see MFM, they are available and we're able to get them in easily. We also have both laboratory services in the building, and then ultrasound on one end of the suite. So we're able to get kind of all those things done, one-stop shopping. Yes, sometimes our patients are there for 3 hours, but we really focused on making that patient-friendly and patient-centered as much as we could, and took out the patient level system barriers. We also created an SUD and pregnancy work group that really crosses from the outpatient setting to the inpatient setting to the pediatric setting to the postpartum care for both for the whole family, to ensure that we were able to make some of these changes. We've had a broad stakeholder group that's been in there, as well as some of our community mental health partners, which have been invaluable in terms of providing some of that community support that we talked about earlier. And we had a lot of staff and we have a lot of staff and leads on that committee, which is great because they are really able to get that engagement from staff in order to make these changes. And then we're able to kind of have a different viewpoint because we're not looking at it from up here, from outside. We're looking at it from a boots on the ground level. These are some of the things that we've accomplished in the last 4 years, which I think is pretty cool. We did a big destigmatizing push education-wise across our hospital. We transitioned to Eat, Sleep, Console, so went from being very healthcare centric to being a very baby centric protocol. Stopped sending all babies at one point. Were being sent to the NICU for monitoring, and really brought that back onto the postpartum unit. Unless baby needs medications, then they do go for monitoring a respiratory rate. We've engaged Child Protective Services as partners. They come to our meetings, so they're part of the conversations. I'm hoping that helps them understand kind of our perspective with these individual patients. We do not talk about specific patients. Sorry, with this patient population, not individual patients. We do not talk about specific patients at that meeting, but we were able to create closer ties with Child Protective Services here in Michigan. Most CPS workers only work for about 2 years, so we're constantly getting new workers and needing to help support and educate them on addiction and the resources in the community. So that's been a really great contributor to our meetings. We've also been addressing, we are a recreationally legal state, so we've also been addressing some of the policies and procedures around marijuana, and we do some patient case reviews that are de-identified for privacy reasons. So postpartum, before Great Moms, I kind of mentioned that most people tended to kind of graduate from the prenatal care at about 6 weeks postpartum, and now we're able to extend that to 1 full year. And we make what I like to call I just stuck my hand in the oven hot handoff rather than just a warm handoff. Our social worker actually continues with the patient in the family medicine clinic so that they continue to receive that support. So here's our data from last year. We were able to, of our 42 babies, only about 5 of them showed symptoms of neonatal abstinence syndrome, and only 5% actually needed medication to treat that. We are very proud of our 6-week postpartum follow-up rate. It's truly because we have the carrot of the buprenorphine. People are coming back for that. They're not coming back for the postpartum visit. We're not that magical, but we do see a pretty high rate of postpartum visits. So we are expanding the program we also now treat other substances as well, of course. And then this is a Blue Cross Blue Shield incentive here in Michigan that we worked on with Blue Cross Blue Shield, and practices that actually receive payment based on having policies, procedures, and treating people with prenatally with MOUD, which is fantastic. That was years of advocacy, lots of conversation. It is actually payer agnostic, which is really nice. So it doesn't matter if they have Blue Cross Blue Shield insurance or not. But that has been a huge point of being able to disseminate and increase the amount of people that are treating opioid use disorder during pregnancy. We've been providing our services now for 6 years. I just really I cannot emphasize enough that when we started, it was me and a nurse midwife in a clinic being like, hey, let's do this. And then putting together that plan for leadership to say, like, we need to do this because this is the risk to patients that is happening here in our region and here in our system. And here's the standard of care and where we're missing it. And then over time, we actually started with a really small Blue Cross Blue Shield grant that actually supported covering our medical assistance time as sort of a to also data track. So we sold it as sort of a program manager-esque opportunity. And it was really fantastic. And that's really how we started, was really just with a really tiny $30,000 grant from Blue Cross Blue Shield Foundation. And now we're teaching and training people across the state of Michigan. So if it seems insurmountable, or if this seems overwhelming to you, as a provider, kind of like the champion in your one clinic, like, I cannot express enough how just those incremental conversations and those little changes really make a huge difference for people. I'm gonna skip over some of these slides, but I often get asked, how did I get into the advocacy thing? And the short answer is, it touched my family. You can see my mother is here and my brother is here. My mother died of sequelae related to a suicide attempt. She didn't die of the suicide attempt, but she died of consequences she died of long-term consequences related to suicide. And then my brother died of a self-inflicted gunshot wound related to his alcohol use disorder. And while I was becoming an addiction physician, when my mother died and when my brother died, I really didn't really like it became much more personal. It became kind of the fire inside of me, and gave me a lot of purpose. Particularly, I got a lot of meaning in my own life when I started speaking publicly about Max, my brother, my mom, and just kind of my general story. My daughter is named after Eleanor Roosevelt. And so just that persistence and that perseverance and that optimism that things can get better, that we can do better, we can treat people better, really has been a guiding light. I spent about 7 years talking about persistence, advocating for increased reimbursement for treating substance use disorder in the outpatient setting. Prior to what's on the screen in terms of the services covered by Medicaid, only opioid use disorder was reimbursed, and only that E&M code at the top there were the only reimbursed codes outside of our behavioral health carve out. So this really changed things in Michigan in terms of being able to bill for both alcohol use disorder and opioid use disorder. Right now Medicaid is working on developing a policy for inpatient coverage of consult services in addiction, which is hopefully going to expand the possibilities in that realm as well. But I tell people all the time, I just kept talking about it. Anytime I met somebody from Medicaid or talked to somebody in the Department of Health and Human Services more broadly, I was like, do you know this about Medicaid? Can we fix this? Like, this is a parity problem. This is, and I had my little spiel about it. In the end, internally, Medicaid referred to this policy as the Poland policy. That was like the shorthand for the policy, because it really was a huge part of what I did in my, spare time working with the state. I think in part as a result of that, and in part as a result of my work with my state professional association, the Michigan MSMS, Michigan State Medical Society. Sorry, I couldn't figure it out. That I was MSMS recommended me to our Opioid Advisory Commission, which is over our our national opioid settlement dollars, which I'm sure many of you are aware of. But Michigan is expected to receive $1.45 billion over approximately the next 20 years. And so the role of the OAC is to advise and support the government, develop strategies, and provide data-driven recommendations. So we came out with our first, we sit under the legislative branch. So I was appointed by our then Speaker of the House, our then Senate Majority Leader, and then it has And then you can see that we sit within the Legislative Council, so we report to the legislature, and we are within kind of their umbrella. So the next steps in terms of what we're doing in the state of Michigan is we are that I'm involved in is I am currently assisting with reviewing CPS rules. We're opening them here in the state of Michigan for the first time since 1994. It's super promising. We have a wonderful team, wonderful core team. They probably need about triple the staff administratively at CPS to accomplish this. So we're happy to be able to support that. But the folks at our CPS are really interested in pivoting to more of a prevention and family-centered care. So being involved in those conversations and also pulling other people in when, for additional voices when I'm not the right voice, is really important. And then, as I mentioned, the DHS is reviewing coverage for inpatient-based addiction services, and as well as providing some funding to increase rooming in and possibly ESC statewide. And then in terms of the pregnancy, parenting, and children, we are actively pivoting our clinic to localize within the residency practice as part of our goal to normalize SUD treatment during pregnancy for upcoming trainees so that when they graduate, it's not an unknown. They currently spend like a day with me during their 4 years of residency, and we have the opportunity to increase that by embedding ourselves within the residency. So with that, I just really encourage you to know that, I know when I used to see some of these presentations, I would be like, oh my gosh, these people are so overwhelming. I don't even know where to start. But just remember, it just started with that simple 20 patient chart review to identify the problem that we already knew existed in our health system, but we just needed a little bit of data to put a magnifying glass on it for others that weren't so intimately involved with this patient population. I left, I think, about 10 minutes for questions, comments, discussion, but I like to end all of my thoughts to all of the people who have lost their lives to addiction and those that try to prevent further losses. It's been an honor to be here today. I really appreciate the invitation to share with this group. I've been joining some of the other meetings that you all are having in Minnesota, and it's just it's inspiring to me to see to be able to take some of that work back to my state. And I was honored to have an opportunity to share with this group here today. There are multiple ways to get in touch with me if I can be helpful, or if you feel your questions would be best answered on a one-on-one basis. Happy to connect with people through a different means as well. And with that, I will pause and see if there are questions or comments.
Awesome.
Or ways that I could improve that you all see.
Wonderful, wonderful, Dr. Poland. I apologize. I think maybe when I was doing the introduction, my internet wasn't very clear either. But I want to say to Dr. Poland, we are so happy to have you. And I think we want you to come back soon and maybe share some more about the work that you're doing. You kind of presented several different avenues and opportunities to intersect around collaboration. And I am sure in your work with being a training doctor, I think is amazing, because we want to hear from those people who are in school and what they're thinking about bringing. So maybe there's a panel or something that's in the future. I just want to leave that with you, because we have wanted to connect more with academia, and we have in medical schools. I just think it's critical. We are moving forward, but we trust that there are other scholars coming behind us that are help ushering in some improvements and some ingenuity. So we thank you so much. I did try to allow people to unmute. We do have a small group. I'm going to stop chatting. If you would like to ask a question or make a comment, you should be able to do so right now. And I'm watching the chat if you are unable to share it audibly. We often have a quiet group. Anyone? I do see lots of thank yous as well for this presentation. We will have the recording posted just for education purposes. Those people will not be able to receive CMEs. And we do appreciate you sharing information so that folks join us. I know that I'll just make another, I know we have some folks from Wayside. And it is a state opioid response grant intersecting with Black maternal health, right? And maternal needs. And we're intersecting in the SUD and OUD community. And I just feel like this is so critical for us to learn together in this space. So, I'm seeing it says my internet's a little unstable. But I'd love to hear maybe Dr. Poland, just going back to some of the training work you've done with the students, if there's anything that you feel like they're leading us into.
Yeah, so that's kind of the other piece of my life is I have a master's degree in education. So I teach and train. I started with physicians. So I have physicians, residents, medical students, as well as psychiatric mental health, DNP students, PA students. Michigan State University is the only university that has both MD and DO programs. So we have both MD and DO trainees. My educational program has been implemented in all of the medical schools in Michigan, except for University of Michigan. They declined to participate in our grant. But we do a lot of teaching, training, education, and support across the state of Michigan. Our programs nationally utilized around physicians. That's actually how I came to know you all. One of your docs did participate in our program. We help people through that practice pathway. And we teach kind of across the educational continuum. We are currently expanding this year with my state opioid response funding. So also a thankful recipient of that support from DHHS into social work education. For practicing physicians, we do have CME that is free. AMA Category 1 CME that's provided by my dean's office. So very lucky to have that office's partnership as well. But we should also have CME that is CAADC appropriate for social workers in the next 18 months or so. So just really excited about that program. But a lot of it's also just that one-on-one, demystifying. The average physician during medical school gets 1 hour of education in addiction. So it's just the unknown is scary. So the more that we can get involved and get in front of medical students, we started a student interest group in addiction medicine. For the medical school in my region. We will come out and do like a pre-brief for residency programs, have them do some of our asynchronous online modules because there's only one of me. I can only teach so many hours, and then come in and do a post-brief with them. So just kind of having those relationships and those conversations with people over and over. And I always tell people, the only thing to do when somebody closes the door is to find that wedge of light. And keep knocking. Just knowing that people's own life experiences related to substance use sometimes come out in their behaviors, and also that we can support people, that we can keep coming back to them, and maybe at some point we'll utilize our motivational interviewing skills. I do see a question in the chat, so I work.
Yes.
Perfect. We're on the same.
Go ahead. You can read it.
It says, I work primarily with the perinatal community and have identified many hospitals and health systems who do not have significant support for pregnant or postpartum patients, even though they may have a program and support for management of NAS or NOWS. Any insight from your personal, professional, or academic perspective? That is not uncommon at all. Where I would start if is if I may, is to find out who are the champions for those programs and find out from them who are the prenatal providers that they think are supportive of this population, because oftentimes they know. And then reach out to those specific people and say, you know, I heard from my colleagues in the NICU that you are doing some, you are just a really strong supporter of people in our community that have substance use disorders. And I'd really like to learn from you kind of what the status is and what your opinions are of where we could go as a system. And just engage in some of those listening conversations to better understand where people are. But I'll bet you that the NICU providers or the social workers and the nurses in the NICU, right? Not just the physicians, but also, you know, in particular, the nurses and the social workers that often spend more one-on-one time with those patients. They know who in the community treats these patients with dignity and respect. So I would start with them and then pull it back to the prenatal side. And then I would also ask them about any generalist pediatricians, generalist OB, you know, hospital-based OBs that they might be able to recommend to you, again, as supportive of this population. But you just got to take that kernel and kind of pull the string back to find out who are those prenatal care providers, and then offering whatever you can to support them, or even just saying, like, I am personally touched and thankful that you are doing this work. Oftentimes we don't hear that, right? And so it can be really nice to hear from a colleague or someone else in our community that, you know, being kind to people with a substance use disorder matters to them or matters to you. Absolutely. And if, as you're having those conversations, you want to talk through what those are looking like, reach out to me. I left my contact information up for an obscene amount of time. So hopefully somebody wrote it down and we'll benefit from that.
Thank you so much, Dr. Poland. I thank you for your transparency. I thank you that your life's journey and the honorarium of your mother and brother brought you to this point, right? That you are able to serve and educate, inspire us in this place. And I too have lost loved ones to substance use disorder. And their humanity matters, their story matters, their journey matters. And we should honor that as well. And what they teach us in life. There's a lot of teaching and learning around compassion and empathy to share with one another. I thank you so much for today. I thank you for the questions. I thank you that there will be follow-up. And I just want you to know that this is a second home for you. To bring forth what you believe is next in this conversation, because this is critical to our organization, caring for women, birthing people, and we can't do this work without one another. So thank you all for attending, and thank you for this amazing talk today.
Thank you. I look forward to future conversations, and I'll have to make it out to Minnesota to visit you all.